You're listening to Medscape's In Discussion series on breast cancer and HER2, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Kathy Miller, Valve Lentero Professor at the Indiana University School of Medicine, Department of Medicine, Hematology Oncology Division. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hi, I'm Dr. Kathy Miller. Welcome to the Medscape In Discussion podcast series on breast cancer and HER2. Today, we're going to be talking about cardiac toxicity. Who's at risk, how often, and what do we do about it? I am delighted to be joined by Dr. Bonnie Key. Dr. Key is the Founders Professor of Cardio-Oncology and the Director of the Thalheimer Center for Cardio-Oncology at the Perelman School of Medicine at the University of Pennsylvania. Her clinical expertise is in non-invasive cardiac imaging by echocardiography and in the care of cancer patients with cardiovascular concerns, risk factors, or disease. She directs a very large clinical translational research program focused on risk prediction and risk mitigation in patients living with and beyond cancer. Welcome to Medscape In Discussion podcast, Dr. Key.
Thank you so much, Dr. Miller. It is truly an honor and pleasure to be talking with you today.
So I want to go first to our first indication that HER2-targeted therapy would have a potential problem for the heart. And that was really the first randomized trial in the metastatic setting where there were two cohorts of patients getting anthracycline-based therapy and those getting taxane-based therapy. And I remember being shocked that roughly a quarter of patients getting concurrent anthracyclines got cardiac toxicity. And I don't mean little blips in their ejection fraction, like real symptomatic congestive heart failure. Was there something about HER2 that we should have known before starting that trial? Was there something we missed that should have predicted that?
That's such a great question and such great insights. And it's always really wonderful to take a look back at the historical perspective of everything. So thank you, Dr. Miller, for raising that question. You know, it's always easy to quote unquote Monday morning quarterback or things like that. And the short answer is I don't think anything was missed per se, but I do think that as a field of scientists, as clinicians across a multidisciplinary field, it is important to always assess and reassess how could we do things the best possible way? How can we design our drugs the most safely as possible? I'd say in those very early studies, as you indicated, anthracyclines and trastuzumab were given concurrently together. And we know that anthracyclines have a very well-established cardiotoxic effect. And I think that in itself led to those very high rates that were initially reported. Subsequent to that, as you know, anthracyclines were given and trastuzumab were given sequentially. And there was a decrease in the cardiotoxicity rates, but it was still quite significant. As you know, since that time, anthracyclines have largely been eliminated, at least in the US, from that regimen, given similar oncologic efficacy and given the high rates of cardiotoxicity. But I think nothing was missed. I think it led to the birth, I'd say, of cardio-oncology as a field. And it has caused us to very carefully look at how should we be best designing our oncology studies to maximize the cardiac signal.
So let's talk about what we've learned since then, because you acknowledged that eliminating the anthracyclines from concurrent use reduces the risk, but it certainly didn't completely eliminate it. So who is at greater risk other than those patients who've had recent or concurrent anthracycline therapy?
Yes, that's a great question as well. And just taking a step back, why do we even think cardiotoxicity occurs? At least with HER2 containing regimens, we do think it may have something to do with mitochondrial dysfunction. So the master energy regulators of the heart, there's some dysfunction there and some stunning. And we largely think these ejection fraction declines or cardiotoxicity, it can recover over time. That's on average, not in everyone, not in all. But who is at greater risk? Again, on average, we think those patients who received prior cardiotoxic therapy, and it's largely anthracyclines, but potentially also other cardiotoxic regimens or agents do include things like left-sided radiation. Also, prevalent cardiovascular disease. So those patients who have a history of coronary artery disease, example, those patients who have a history of heart failure, and those patients who start with an ejection fraction that is not normal. So we often consider less than 50%, 50. Also, patients who are older, patients who have cardiovascular risk factors, so hypertension, diabetes, obesity, dyslipidemia. And I think we still do not know exactly why, but there are certain racial predispositions. We know that race is a social construct, but there are data to support that Black African Americans are at increased risk of the development of cardiotoxicity with HER2-targeted therapies.
So, really, it's the people who we're likely to find hanging out in the cardiology clinic. Obesity, hypertension, diabetes, older age, previous cardiovascular disease. One that I think of when I think of the patients who are in my cardiologist waiting room that you didn't mention that I have to ask you about is smoking. Does that also increase the risk of cardiac toxicity from our therapies?
Yes, I would add that, of course, and thank you so much for adding that. Certainly, smoking, tobacco history places patients at increased risk of cardiotoxic effects.
So I want to shift to evaluation. And I know your expertise is in echocardiography. And I also know that this is a topic hotly debated in cardiology. Does it matter if I'm interested in the ejection fraction? Is it better to measure this by echo or by MUGA or by MRI? Is there one that is more accurate?
That's a great question as well. I think it comes down to accuracy and precision, as well as feasibility, patient experience, and patient risk. By and large, in the field of cardio-oncology, I'd say that echocardiography is our first go-to choice. A lot of that has to do with what's accessible, also lack of any ionizing radiation, so really important to the patient. And you can, with careful review, obtain accurate and precise estimates. MUGA has largely fallen out of favor because of the radiation exposure and because you can't get a lot of other information. You can't get insight into valvular disease, diastolic function, i.e., how does the heart relax, and so forth. I'd also say, in terms of other modalities such as MRI, that can be challenging to obtain in terms of just the accessibility. Also, cost. MRIs are more costly compared to echocardiograms. Within echocardiography, I'll just add there is this new modality called strain. There are a lot of differing controversial views on that. It's very much correlated with ejection fraction, but it's also very much image dependent, vendor dependent, and so forth. So there are a lot of caveats there too in terms of how it's being acquired. And one big take home message to the audience is to not make a treatment decision for the patient based upon a strain value alone. I just wanted to make sure that that gets across.
You just hit on one of my consistent points of argument with my local cardiologist and my complaints. When we've looked at the risk of heart failure with HER2-targeted therapies in patients who've never had an anthracycline, it's not zero, but it's exceedingly low. So the study that is top of my mind is a study known in oncology circles as the APT trial that looked at just 12 weeks of single agent paclitaxel with trastuzumab for a year in patients with stage 1 or early stage 2 disease. So they'd never had previous therapy. It was a study of about 400 patients. And there was one patient who had an ejection fraction that dipped below normal at a single time point that then, with subsequent holding treatment, came back up. And as we were writing that manuscript, we actually included in the discussion that these data argued that we are over monitoring patients for heart failure if they've not had previous anthracyclines or major other risk factors. But because monitoring was part of the FDA label recommendations, the sponsor made us take that part out of the discussion. The data were still there, but that was not one of the recommendations that we were able to discuss. I find some cardio-oncology studies difficult for me to support and interpret because it feels like they've expanded the definition of significant cardiac toxicity to changes in strain with nothing else, or a drop in ejection fraction that is transient and not associated with any symptoms, partly for the pragmatic reason that if the rates are so low for really clinically evident congestive heart failure, you can't do the studies. So you have to expand them. But I don't know what a transient drop in ejection fraction that goes back to normal means for my patients 20 or 30 years down the road. And I have no idea what a change in strain for them as the only change means. What should we be paying attention to when we're monitoring patients in clinic or as we're designing clinical trials?
Another great question. I think there's so many different facets to what you just shared that I think are important for the community to be aware. I agree that the rates are relatively lesser, especially compared to what was first reported decades ago. There was a recent study reported from MD Anderson describing their real world experience in their clinic. As you know, we often are concerned that oftentimes the clinical trial data may not be broadly generalizable to all the patients we see in everyday practice just because of various inclusion exclusion criteria. They noted a rate across all comers, and this did include patients who received anthracyclines, about 9%. And this is in terms of ejection fraction declines or changes, which we often use definitions of greater than or equal to 10% to less than 50% or so. The rates of severe heart failure are very, very low, less than 2%. Well, I'll also add, in terms of that rate, there is a range. In those patients who we deem low cardiovascular risk, the ejection fraction declines probably on the order of 3%. And those patients at higher risk, those patients who receive sequential therapy, probably up to 33% or so, but on average, 9%. There is definitely a movement in cardio-oncology, I'd say, to lesser monitoring. There is a body of evidence being generated to support that. Another trial from Memorial Sloan Kettering, I should say, from our colleagues there, looked at the approach of every 6-month monitoring as opposed to every 3-month monitoring in patients deemed low risk. And they determined that that was feasible and safe. And there's only one cardiac event that was reported in that trial. That was led by Anthony Yu and colleagues, again at Memorial Sloan Kettering. That's point number 2. So definitely a push to lesser monitoring. And I think we just need to determine which is the group that can be monitored less, not the every 3 months, which is that lower risk group, and personalized monitoring as well. Point number 3 I'd like to make is that I agree with you about these definitions of cardiotoxicity. And the field has a lot of work to do we've done a lot of work, but we have a lot more work to do in order to develop what we think are consensus definitions of cardiotoxicity that are clinically relevant to the patient and to the provider. I agree that we struggle with these changes in strain and what they mean for the patient and what they mean for the clinician. And I honestly agree with you that we should, as I alluded to before, we should not be making treatment decisions based upon strain changes alone. That these definitions that incorporate them, I think, are limited. Ultimately, again, what we need to determine in terms of our clinical trial design is what matters to the patient and what matters in terms of ultimate clinical outcomes. And I think the field needs to generate that evidence that says that does mild cardiac dysfunction by certain definitions, does that matter in terms of overt clinical outcomes? Does it matter in terms of heart failure and so forth? Because the greatest mistake I think we can make as a field is stopping therapy, stopping potentially life-saving cancer therapy unnecessarily for these strain changes that ultimately will not matter. We cannot do that as clinicians, as care providers. That would be a huge disservice to the patient.
It's a fascinating twist from almost being at times an adversarial relationship. I remember early in my career that the specialist definition of cure was that my patients died of someone else's disease. preferably a long time in the future. But I certainly don't want to be responsible for someone's heart failure in their 70s because of treatment I gave them in their 40s. But I also don't want them to die in their early 40s because they didn't get the therapy they needed to prevent them dying from their breast cancer so they'd have the opportunity to live to 70. So I think some truly long-term follow-up data, which we're now getting into the realm of being able to do of patients in those early trastuzumab HER2-targeted therapy trials, it is going to be really important for us. I'm also curious if your monitoring recommendations and strategies are different in patients with curable disease who are going to be receiving a defined duration of therapy versus those with metastatic disease. Because as much as I was horrified by that 27% rate of congestive heart failure in the foundational trial, I am comforted by the fact that despite that, there was an improvement in that cohort in overall survival. So there is a real risk of stopping therapy for minor changes that don't have clinical consequence and that being harmful. So do you adjust your strategy based on the situation?
Yeah, we do try to personalize. I will say that although to my knowledge, this has not made it into any kind of strict guidelines or any, certainly not any FDA guidance, but some in the metastatic setting will move to every 6-month monitoring, especially if everything's been very stable. And I will say that in terms of observation of cardiotoxicity declines or declines in ejection fraction, usually when we're going to observe that, oftentimes it is within the first year of exposure of therapy. So if you have a patient in the metastatic setting who's been tolerating therapy without any changes in ejection fraction, anything, any abnormalities in diastolic function, and these other things we look at on echo, like pulmonary pressures, valve disease, and they don't have a large burden of cardiovascular risk factors over cardiovascular disease, it likely is okay to go to less frequent monitoring. I'll say one other reason to monitor, of course, speaks to this notion of permissive cardiotoxicity. So if a patient does suffer from a decline in ejection fraction, this is also building on the prior point I was making about stopping therapy or not wanting to stop therapy because it can be potentially life-saving, of course, as we said. But in patients who suffer from declines in ejection fraction, and this is detected by echocardiography and biomonitoring, there is a notion that we can continue HER2-targeted therapy safely with the addition of cardioprotective medications, neurohormonal therapy. This is ACE inhibitors, beta blockers, angiotensin receptor blockers, and even ARNIs, neprilysin inhibitors. And Charlie Porter, your colleague, and Tochi Oguosa coined this term permissive cardiotoxicity. And there are 2 small trials that have spoken to this concept, SafeHeart and Scholar, whereby patients who had an ejection fraction between 40 and 50%, they were treated with neurohormonal therapy and carefully monitored under the care of a cardiologist. And by and large, the majority, 80% plus, were able to continue their HER2-targeted therapy despite a decline in ejection fraction.
So in our last few minutes, I want to ask you a bit about risk prevention and risk mitigation. If I have somebody with HER2-targeted disease who has, say, an ejection fraction that is normal, but just above your 50% threshold, maybe it's 47%, they don't have symptoms, but they have other risk factors, but they also have stage 3 HER2-positive breast cancer. Are there things that we could or should be doing to try to increase the safety of their treatment?
I would definitely say to refer to a cardio-oncologist or cardiologist colleague who has expertise in this area is number one. I always am wary of the low normal ejection fractions, and certainly some with the 47, I would consider that abnormal. I would consider that as a mildly reduced ejection fraction. And in that setting, I tend to be very aggressive about neurohormonal therapy, ACE inhibitors, beta blockers, ARNIs, ARBs, because of the need for continued HER2-targeted therapy. I want to do everything I can. I'm working with the patient and with the oncologist and the entire care team to avoid stopping or holding HER2-targeted therapy because we recognize how important it is. So I definitely think in the scenario that you just explained that I would be a strong proponent of neurohormonal therapy. There's some retrospective data to support potentially statin therapy as a cardioprotectant. That's retrospective, not prospective in the setting. And then in the cardiology world, we really love SGLT2 inhibitors, I'd say. So that's another therapy that I might consider depending upon all the various patient-specific factors.
Dr. Key, thank you for joining us today. We've been discussing the cardiovascular concerns with HER2-targeted therapies and how to work with our cardiology colleagues so that our patients can continue treatment and be safe. For our listeners, remember the rates of cardiac toxicity in patients who are not getting concurrent or previous anthracyclines are quite low, but they're not zero. Understanding baseline ejection fractions, understanding other cardiac risk factors is going to remain important. We do think we're at a time where we can begin to think about individualized monitoring strategies, that not everybody needs every 3-month cardiac assessments for the entire duration of time that they're on HER2-targeted therapy. That's probably particularly true in patients with metastatic disease, some of whom may remain on therapy for decades. And as we learn more about the biology, we will learn more about how to individualize our risk mitigation strategies as well. So if you have not found your local cardio-oncologist, now's a good time for you to do that because there will be other agents. There already are other agents commonly used to treat other types of cancers where cardiac toxicities are a concern as well. We will need to continue to work hand in hand to find that balance of treating our patients as well as possible and as safely as possible so that we're not just swapping one bad problem for another one. Dr. Key, thank you for joining me.
Thank you, Dr. Miller. So well said.
And to our listeners, thank you for tuning in. Please take a minute to download the Medscape app to listen and subscribe to this podcast series on breast cancer and HER2. This is Dr. Kathy Miller for the Medscape In Discussion podcast.
Thanks for listening to Medscape's In Discussion Breast Cancer and HER2 podcast series with our host, Dr. Kathy Miller. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on breast cancer and HER2.